and welcome to the New Cardiovascular Horizons digital educational series. This presentation is an update in renal denervation. I'm Dr. Richard Kovach. I'm Division Director of Interventional Cardiology at DeBoer Heart and Lung Center in Browns Mills, New Jersey. I'm also Medical Director of our Cardiac Catheterization Laboratory. I'd like to thank Dr. Craig Walker and the entire NCVH team for putting these presentations together and for the opportunity to speak. These are my disclosures. Before delving into renal denervation or the reasons for it, I thought it'd be worthwhile to do a bit of a review about the worldwide prevalence of hypertension and how we're doing with treatment. It's estimated that by the year 2025, 1.56 billion or 29% of the world's population are going to be projected to have hypertension. Most of that increase will occur in economically developing regions. In spite of the fact that we are what we would consider a well-developed economic region in the U.S., our identification, treatment, and management of hypertension is still far from optimal, as this slide demonstrates. This study was presented in Journal of Hypertension in 2004, so a bit old, but I think the same statistics or similar statistics still hold true today. Roughly 50% or greater of patients with hypertension are not being well controlled. Prevalence of hypertension and control rates. Well, since the 2017 ACC/AHA guidelines were updated, much larger number of patients are now considered to be hypertensive. Significant increase in number of classified hypertensives is associated with a simultaneous significant reduction in the percentage of patients who are adequately controlled hypertensives. We know that cardiovascular mortality is tied directly to hypertension, obviously one of the major cardiovascular risk factors. For every 20 over 10 millimeter increase in blood pressure, there's a twofold increase in cardiovascular mortality. Interestingly, though, even with small reductions in blood pressure, 2 millimeters of mercury in mean systolic blood pressure is associated with a 10% reduction in the risk of stroke mortality and a 7% reduction in the risk of ischemic heart disease mortality. So even, again, I think it's important to stress, small reductions in blood pressure have a substantial impact. Unfortunately, in spite of what we know about hypertension, compliance and persistence with antihypertensive therapy typically falls to less than 50% after 1 year. Non-adherence to antihypertensive therapy is probably the major cause for poor control. It's estimated that 4.9 million Americans, or 26% of Medicare beneficiaries, are non-compliant and non-adherent to therapy, and as much as 50% of the general population on treatment for hypertension. Looking at the other side of the coin, high adherence, greater than 80% to antihypertensive therapy, is associated with 11% lower relative risk of developing heart failure, a 10% lower risk of developing coronary artery disease, and a 22% lower relative risk of developing cerebrovascular disease. Extremely important to manage hypertension properly. So now that we've discussed the problem, let's look at a new alternative for management of hypertension in place of and or in addition to medical therapy. So why has there been this attention or focus on the concept of renal denervation? Well, we know that there is a feedback loop between the central nervous system and the kidneys. The sympathetic nervous system, there are efferent fibers which run from the CNS to the kidneys, which modulate the physiology of the kidneys. And in return, there are afferent nerves back to the CNS, which alter CNS activity. So the concept is, well, if we can interrupt that feedback loop, we most likely or theoretically will have a substantial impact on hypertension. We know that central sympathetic drive is associated with virtually every type of hypertension, as this chart illustrates. The idea that we can actually somehow intervene on those nerves and that feedback loop comes from a fortunate anatomic finding, and that is that the nerves in this feedback loop tend to arborize around the renal arteries and the main branches of the renal arteries, as well as auxiliary arteries. So the concept is, well, if we can somehow affect those nerves, ablate those nerves, interrupt that feedback pathway, we can impact the degree of hypertension. Those nerves are typically located in the adventitia. The idea of sympathectomy to control hypertension is not a new one. In fact, in this article presented by Dr. Smithwick in 1952, discussed surgical sympathectomy in patients with severe uncontrolled hypertension. Unfortunately, these types of surgical procedures are associated with extremely high morbidity and mortality, and really not a practical way of intervening on the sympathetic nervous system. So fast forward to the 2000s, the advancements of catheter-based therapies, and it's natural to look at catheter-based methods of intervening and addressing the sympathetic nerve pathways. This was first addressed in the Symplicity Hypertension 1 study. It was a first-in-man feasibility study with an initial cohort of 50 patients, which was subsequently expanded to 153. Again, the technology took advantage of the fact that these nerves are arborized around the renal arteries. In this particular device, radiofrequency ablation was used in order to damage or destroy the nerves. A series of at least 4 to 6 burns were carried out within the renal arteries bilaterally. The catheter was abutted against the renal artery, and a 120-second burn was carried out with RF ablation in order to limit the or reduce the likelihood of creating a stenotic lesion. Burns were performed in a spiral pattern rather than in a straight circumferential pattern. Again, basically turning the catheter 60 to 90 degrees with each burn to create a spiral pattern of burns, which would theoretically affect all the nerves that were arborized around the renal arteries. This initial study actually had extremely promising results. Even out to 36 months, as this slide demonstrates, there was a highly significant and persistent reduction in both systolic and diastolic blood pressure. Symplicity 1 was followed by Symplicity Hypertension 2, which looked at 6-month office blood pressure measurement. Again, at 6 months, there was a highly significant reduction in both systolic and diastolic blood pressures. I would point out that these types of blood pressure reductions are more that are typically seen with most pharmacologic hypertension trials. So this brought us to Symplicity Hypertension 3, which is a multi-center trial, 90 sites in the US, prospective randomized blinded control study, the control being a sham procedure. Primary outcome was change in office systolic blood pressure from baseline to 6 months. Unfortunately, Symplicity 3 did not yield similar results as seen in Symplicity 1 and 2. Symplicity 3 did not reach the primary efficacy endpoint of office blood pressure reduction. Symplicity 3 also did not reach the secondary efficacy endpoint of decrease in 24-hour ambulatory blood pressure reduction. Fortunately, there were no safety issues associated with this procedure protocol. Possible explanations for the lack of positive results was that in both Symplicity 1 and 2, there was lack of blinding. Symplicity 1 did not have a control group. In Symplicity 3, there were no roll-in patients. Multiple sites were used with quite often inexperienced operators. And we have to remember that this was first-generation technology. Appropriate wall contact of the RF ablation catheter could not be confirmed, as well as true and complete helicoburns were unable to be confirmed. In fact, pathologic specimens from animal studies demonstrate that a true helical or circumferential burn was almost never accomplished, and many times the burns were inadequate or incomplete. As compared to these early European studies, 1 and 2, there was a more heterogeneous study population than in these studies. And also, pharmacologic regimens were not standardized post-procedure. So what did we learn from early renal denervation studies, and particularly Simplicity 3? Number one, we need improved technology. Number two, we need reproducible procedures. And number three, we need robust clinical study design. So that brings us to two studies I'd like to discuss in more detail using updated and current technology. The first is the Paradise Endovascular Ultrasound Ablation Catheter by Recor Medical. This study employs high-frequency ultrasound in order to damage these nerves that are arborized around the renal arteries. The advantage of this catheter is that it creates a circumferential burn. Apposition to the vessel wall is confirmed by the use of a balloon catheter. In addition, cool water circulates through the balloon catheter in order to protect the endothelium and keep the endothelium from being damaged by the ultrasonic waves. This has two advantages. Number one, it reduces the risk of damage, which might result in long-term restenosis, and also preserves endothelial function. 2 to 3 ablations lasting 7 seconds each were delivered in each of the main renal arteries, as well as suitable accessory arteries and large branch vessels. Nerve targeting goal. Well, we know that the nerves run in the adventitia, so the ultrasound is focused to deliver maximum energy from anywhere from 1 to 6 millimeters from the balloon source. And targeting in such a fashion will ablate roughly 80% of the nerves. Again, this is a much more accurate and complete way of delivering renal denervation than the somewhat, if you will, random way of delivering with the first generation catheters. This catheter was investigated in the RADIANCE Hypertension Solo and Trio studies. For the purposes of this discussion, we'll discuss the RADIANCE Solo cohort, which was looking at patients with essential hypertension, which is the majority of our patients. These patients' meds were discontinued. Washout was carried out for 4 weeks with home blood pressure monitoring. Assuming that the patients satisfy the blood pressure inclusion criteria, they were then followed up with CTA, MRA, or duplex to rule out any underlying anatomical abnormalities which would preclude the procedure, specifically renal artery stenosis. And then they were randomized in a 1-to-1 fashion to either renal denervation or a sham procedure. The primary efficacy endpoint, again, was difference in daytime ambulatory systolic blood pressure at 2 months. This is just a brief summary of the procedure details, which we don't need to dwell on. But again, relative to the earlier generation device, RF ablation device, this procedure is actually quite quick. So at 2 months, change in daytime ambulatory systolic blood pressure was significantly improved, or blood pressure significantly reduced in both the intention to treat analysis as well as the per protocol analysis as reported in Lancet in 2018. Change in blood pressure was noted across all efficacy endpoints, including daytime ambulatory blood pressure, 24-hour ambulatory blood pressure, nighttime ABP, office blood pressure, and home blood pressure. Also analyzed was a number of pre-specified subgroups, and there was a reduction in blood pressure across all these subgroups. Patients also, 20% of patients evaluated, that is, with daytime ambulatory blood pressure or 24-hour ambulatory blood pressure, 24% reached hypertension control without the addition of any antihypertensive medications, which I think is remarkable. Drop in daytime systolic ambulatory blood pressure 2 months was also stratified by accessory arteries and completeness of treatment. If there were no accessory arteries or all main and accessory arteries treated, blood pressure reduction was greater as compared to patients who had untreated accessory arteries or unilateral treatment. Untreated accessory arteries, I should mention, were arteries less than 2 millimeters in diameter. There were no adverse safety events noted in this protocol. An updated version of the RF ablation catheter was used in the spiral hypertension studies, reported at ESC in 2017 in a recent Lancet publication. We'll look at that catheter in a moment. But this study looked at blood pressure changes from baseline to 3 months, 24-hour ambulatory blood pressure monitoring and office blood pressure monitoring. Again, with this newer RF ablation device, there was significant reduction in blood pressure, both systolic and diastolic, at 2 months in both of these subgroups. Again, the reason for that is most likely a new design in the catheter, resulting in more complete and circumferential burns using the RF ablation. This is a spiral-shaped catheter with multiple electrodes. Its shape assures adequate apposition to the vessel wall, and multiple electrodes arranged in a spiral fashion ensures a more circumferential burning of the nerves. In addition, as already mentioned, in addition to accessory arteries, the main artery as well as branch vessels were treated with this catheter. Again, more complete ablation of the renal nerves. On medications, 24-hour ambulatory blood pressure change from baseline to 6 months was significant and sustained, as it was in random office blood pressure change, again, from baseline to 6 months. Again, as with the ultrasound catheter, there were no safety concerns whatsoever. So, conclusion of the recent trials, I think the newer generation devices have given biologic proof of principle for the efficacy of renal denervation. Clinically meaningful blood pressure reductions at 2 to 6 months have been demonstrated, along with no major safety events. So I think in conclusion, we can say safely that renal denervation, certainly in 2020, is not dead. And certainly given the fact that as practitioners, management of hypertension is certainly what I'd call suboptimal, with not any prescription of appropriate antihypertensive therapy, but adherence to appropriate antihypertensive therapy. So is renal denervation an alternative to lifelong polypharmacy? I'm not sure that it's a complete replacement, but I think that renal denervation certainly should become one of the tools in the armamentarium to address this very significant disease and health problem. Thank you.